Hello and welcome to this Vet Space module brought to you by Elanco New Zealand, which is regarding the approach to canine otitis externa. My name's Debbie Simpson and I have a referral dermatology business called The Skin Vet, which is based in Auckland. When a dog comes in with a suspected ear infection, whereabouts do you start? For us, it's just the same as in every case. You always start with the history and physical exam. And before we even pick up the otoscope, we're wondering, is this really an ear infection or is there just irritation present, e.g. head shaking? And if there really is an infection there, why has it happened? Is it the first time that it's happened, or is it an ongoing refractive problem, or is it a seasonal problem? And also, does the dog have any other skin signs? Is the dog a swimmer? And are they otherwise well? Do they have any signs of an endocrinopathy or any neurological signs that could give you a clue as to the underlying reason why this dog may have ear disease? Why do dogs get ear infections in the first place? There are primary, secondary, and perpetuating causes. Primary causes are those that can create disease in a normal ear. So if it is a first-time otitis, the basic questions I think about are, is there something down there like a polyp or a foreign body? Is the dog getting their ears wet with swimming or at the groomer? Is the owner or the groomer plucking the ears? And are there any other skin problems like allergies, any signs of food allergy or environmental allergy? Primary causes are those that can start an ear infection on their own. If you can identify and treat those problems, you might fix the ear disease. The main ones that we see are allergies, particularly food allergy or atopic dermatitis, and also foreign bodies such as plant material or grass seeds, insects, or infectious disease like ringworm, aspergillus, demodex, ear mites, and ticks. Allergy is a really common cause of ear disease. Bilateral ear pruritus and otitis externa occurs in about 80% of food allergic dogs. It can be the only clinical sign in 20 to 25% of dogs. It can be hard for an owner to understand that recurrent ear infections are really a sign of food allergy. It's counterintuitive to think that only the ears could be affected, but in many cases, this is the reason. If food is the trigger and there are no other skin areas affected, it does make it very hard to monitor a diet trial if ears are the only area involved. It's much easier if the dog is also scratching or licking their feet, because that's something that the owners can monitor at home. Atopic dogs also have otitis externa in 50 to 80% of cases, and it can be the only clinical sign in 10 to 20% of atopic dogs. Secondary and perpetuating causes don't cause disease by themselves, but they do perpetuate the problem, and you need to treat these causes to resolve the otitis. Examples of these include bacteria, fungi or yeast, otitis media, and also chronic canal changes such as hyperplasia. With chronic disease, the ears can actually physically change. The ear canal gets narrower and calcifies. There are sebaceous glands at the entrance to the ear and in the vertical canal. And there are apocrine or ceruminous glands deeper in the dermis and adjacent to the tympanum. In the healthy ear, most of the cerumen or wax is made by the sebaceous glands at the entrance to the ear. But in the diseased ear, most of the cerumen or wax is made by the ceruminous glands deeper in the dermis and further down the ear canal. The ceruminous gland wax is more acidic to try and kill off the bacteria. It's really important to have a look down the ear. You really need to know if there's something down there like a grass seed or a tumor. You need to know if the eardrum is intact or not, as this guides your choice of medication. So, as is often the case with dogs with sore ears, the dog is really wriggly or aggressive, then you need to sedate them. If the dog is too unstable to sedate or the owner can't afford to sedate the dog, and it's the first time occurrence of otitis and there are no neurological signs, you might get informed consent to treat without an otoscope exam. But if I don't get to look in the ears, then it's just about getting informed consent from the owner and informing them about the possible risks. So I have an actual pre-written template for owners that I just drop into my letter. And I explain to them that and this is it, that reproduced here. So I explain to them that the eardrum is a barrier between the outside ear canal and the middle ear, where the nerves for balance and hearing are located. When dogs have an ear infection, we use drops in the external ear to treat it. And I explained to them that the eardrum is like a protective cover that stops the drops getting further into the ear. So I actually put this written thing into their letter saying that if the dog's ears are too sore to be examined or too narrow, if it's physically impossible to examine them, or if there's material in the way that we can't see past, like pus or wax or hair, then we offer a sedation or an anesthetic to clean the ears. But if we can't do that, then we may decide to use eardrops anyway. But there is a risk that the eardrums may not be intact. We don't know because we can't see them. So I just warn them about the types of things to watch out for. And those things are loss of hearing, loss of balance. And the loss of balance includes things like ataxia, circling, a head tilt, or nystagmus. So I explain to the owners what those things look like, and just say to them, look, we can try drops, but it's not ideal to not be able to look down the ears or see the eardrum. However, let's try the drops. And if any of these signs occur, or if anything worries you, then please stop the drops and let us know straight away. The external ear canal of a dog is L-shaped. It has a vertical and a horizontal part. At the end of the ear canal is the eardrum, and beyond this is the middle ear, which connects to the inner ear where the nerves are for hearing and for balance. The facial nerve, colored yellow in this diagram, crosses through the middle ear. Then it leaves the skull just behind the ear opening. If there is a middle ear problem, the types of things that you can see are reduced lacrimation or tear production, because the facial nerve is motor to the muscles of facial expression. Problems can affect the muscles of the ears, eyelids, nose, cheeks, and lips. And so if the dog can't close the eyelids properly, especially the lower eyelid, or they have a paralyzed or dropped ear or lip, then there may be involvement of the facial nerve. Nystagmus and head tilts are signs that should alert you to the possibility of middle ear involvement. Drooping eyelid and a lip on one side. It just means the middle ear or the ear area around the ear canal can be involved, such as with a paraoral abscess. Why is it important to know whether it's otitis externa or media or both? It's important because it guides you as to your choice of medication, and it gives you a heads up as to how severe the disease could be. Clinical signs of facial nerve or middle ear involvement are deafness, head tilt, nystagmus, circling, ataxia, Horner's disease, loss of balance and hearing. So if any of these make you suspicious, then it's time to consider advanced imaging such as radiography, video otoscopy, or CT or MRI. So always think about whether the middle ear might be involved or not. I also have a little template that I drop into my physical exam to remind me what I'm watching, what I'm looking for. And it prompts me to look at things like symmetry of the face, movement of the eyelids, etc., so that I can just write something next to all of those. It makes my physical exam really simple. These are some examples of imaging to look at the middle ear. So we've got radiography, obviously with this bulla being normal, with the bony structure showing up radio opaque here, and the air-filled bulla being more black. And on this side, there's more radio opacity showing that there's a fluid or soft tissue intensity in this radiograph. And then over here, we've got a CT scan where the bone is white, and you can see the air is black. And this area here is where the eardrum is. And there's obviously something going on in this bulla. A lot of dogs really don't like their ears being examined, and it's important for us to look after ourselves and our staff. So always use a muzzle or sedation. And it's important to know, to really make that effort to have a look, because if the eardrum is not intact, then some medication should not be used. Even if the dog is absolutely perfect, it can be hard to tell if the eardrum is intact. And really the only way can be with ear flushing. So the video otoscope does help a lot. If you're not sure, can't see, and the owners are interested in video otoscopy, you can refer the case. So what should you see? You should see an eardrum like this with the white bone here, the manubrium of the malleus, and the C shape always points forward. So the small part of the C is towards the head or rostral, and the larger curvature is caudal. So then you have the pars flaccidum, which is this kind of balloon type area here, which can change shape with pressure in the middle ear. And then you have the pars tensor, which is really tight like a drum, that it doesn't move at all. And this is the part you should aim for if you're doing a myringotomy, is down here. What do you actually see when you look in an ear? Often you just see a dark hole that often can be confusing as to whether the eardrum is actually ruptured. You're not sure if it's a big gap or if it's wax or what could be there. And often you just see a whole lot of muck you can't quite see around the corner, and you definitely can't see anything as beautiful as your nice eardrum from here. This plug of wax on the left here, when we actually pulled that out, it was quite long. So you really can't tell how long the plug is by looking at it end on. You've got to remove it. So we have lucky enough to have a video otoscope at the Skin Vet. This is Ellie and I doing an ear flash on a dog. And Ellie has the camera, and I've got some biopsy instruments which are being fed down through the camera to grasp that plug of wax. And we also you can see on the table, we've got I prefer to flush manually. So I just use a 10 ml syringe and a feeding tube, and I feed that down the camera so that I can be really gentle and have a lot of control over what I'm doing. This is just a little video of what you see down the video otoscope when you get down the bottom. And if you're trying to work out if this is an eardrum or just a bit of keratin or macerated debris, then you actually pulse the fluid, and you can see this eardrum moving in and out. So I'll just replay that. As we pulse the water, you can see that eardrum. So we know that that is definitely an eardrum. We're looking for normal movement of the eardrum with flushing. If you're not quite sure, if it's not moving well, you can give it a little poke, not too vigorously. And if any air bubbles come up from the middle ear, that means there's a tear in the eardrum. Or if any fluid comes out the nose, there's a tear in the eardrum. And if you can see the bone of the middle ear, then there's no eardrum. So these are just some pictures that you can see the remains of the eardrum there. These are the little oozing bubbles, which you commonly see. And we always check the nose during the procedure to see if there's any fluid actually coming out through the nose. This is why we use the incontinence sheet over the head, to protect water from just dribbling down the face. This pars flaccidum up here, this part that bulges in and out, is completely normal. It bulges with increased middle ear pressure. And often we are sent these cases because people think that this is a mass in the ear, but this is actually just a normal structure. So what's the next step? Cytology is absolutely critical. Just take a cotton tip, sample both ears, roll them out gently on a slide. How you do this is personal preference. I just always put the frosted part on the left and put a little swab from the left ear on the left side. And that way, it's just a visual memory thing as well, that when I put it on the microscope, I always have the frosted part on the left. So I know that the first ear that sample that I look at is the left ear, and the second is the right. And if I'm back in the room and trying to think, oh, which ear was the ear with the yeast in it, I was like, was it the first one I looked at or the second? If you're consistent, it just can help you remember. So what am I actually looking for on cytology? Cocci, as seen on the left, rods, as seen on the right, neutrophils, yeast, as seen in the middle picture. Sometimes you can even see Demodex or ear mites. Common bacteria that you see are Staph pseudointermedius, Strep, Pseudomonas proteus, and Corynebacterium. Malassezia are very common as a secondary infection. Something that you wonder sometimes is how many yeast is acceptable or normal. About 1 per 5 high power fields is acceptable. You might also see Aspergillus or dermatophytes and wonder, are these important? Are they contaminants? When you look at cytology, what you're trying to think about is it a pure growth of just one thing, in which case it might be more pathogenic or harder to treat. You often see this with Pseudomonas. If there's a whole lot of mixed bacteria and yeast, it's probably not just one pathogen. So we're thinking the problem is with the ear rather than with the bug. Why are neutrophils important? Neutrophils really guide your choice of medication, and aminoglycosides really don't work well in the presence of neutrophils. So if there's a lot of pus, then don't choose aminoglycosides. Use systemic prednisolone to reduce inflammation. This decreases the numbers of neutrophils and makes the dog a lot more comfortable. Examples of ear medications that do contain aminoglycosides would be Ezotic, Otomax, and some others. So these are not good choices when you see pus. A really common question that I'm asked is whether an ear culture is useful. I would say usually not. Cytology is a lot more important. Culture just tells you what grows well in the lab, and cytology on the day tells you what sort of microorganism is down there and what proportions. If it's ear mites, you're not going to be able to culture them. Cytology is a really useful tool and something which is just critical in treating ears well. There are some drawbacks to ear cultures. The sensitivity that you get reported on your panel just tells you whether the level of drug achieved in the blood for that antibiotic is going to be effective against the bug. But we are not trying to treat the bacteria or yeast with an oral medication. We're putting it directly down the ear on top of the bacteria. We're not relying on oral antibiotics to treat an external ear infection. And the levels of medication achieved when you use a topical are far higher than the level of antibiotic when a pill is swallowed, gets to the stomach, gets out in the blood, and then gets back into the skin of the ear, and then through all the wax and pus and everything else to the actual bug. You need a lot of antibiotic to get there. So most of the time, a drug will work, even if the sensitivity panel says that it's resistant, for example, to enrofloxacin. If you put enrofloxacin directly on top of some cocci, it will kill it. If you swallow a Bactrim tablet, it may not. NAVDF just stands for the North American Veterinary Dermatology Forum, which is the American dermatology conference that's held every year. And in 2010, David Robson presented this abstract, the purpose of which was to compare the clinical response to empirically selected eardrops with response predicted by culture and sensitivity. So he took 16 dogs with rods identified on cytology as the predominant microorganism, and then selected a treatment of a topical and steroid purely on the basis of cytology and clinical exam with no culture. No systemic antibiotics were used. Pseudomonas was isolated from all these cases, either pure or mixed with other bugs, and 10 out of the 16 dogs tested resistant to the drops used. However, 8 of these responded anyway. So that's 80% of dogs that should have been resistant responded. There was a 2004 study by Ed Rosser and Graham Mees, and these guys took 2 samples from the same ear, sent them to the same lab on the same day, and 20% of them grew different bugs. 20% grew the same bugs, but different sensitivities were reported. And only 60% grew the same bugs with the same sensitivities. And this is same dog, same ear, same lab, same day. So therefore, how useful are these cultures? When you're trying to work out how to tip the balance in your favor, then there are some medications to think about. When you see neutrophils, glucocorticoids are your friends. They're antipyretic, anti-inflammatory. They decrease sebaceous and apocrine gland secretions, and they're really useful, which is why they're in most eardrops. You can use them by themselves if the only problem is neutrophils, or if you're trying to treat just allergic or streaminous otitis. Cortivants can be useful to dry the ears and settle inflammation. This is off-label, so you do need to check that eardrums are intact, as it can be ototoxic if the tympanic membranes are compromised. Odoflush, this is our second really, really useful medication to tip the odds in your favor. It changes the pH in the ear and makes it more alkaline. Aminoglycosides and fluoroquinolones are more effective at an alkaline pH. This chelates metals, which are part of the bacterial cell membrane. And Pseudomonas uses a calcium-mediated efflux pump to pump out drugs. Tris-EDTA blocks this pump. So that means that the rod cell membranes are perforated and the other drugs can get in to actually kill the bacteria. So the other medication, just move this around so you can see the slide, to tip the balance in your favor. This is when no one can get near the dog to put drops in. So these leave-in medications are a lifesaver in some cases, literally. And the options that we have here in New Zealand are Ocernia, which is designed to be used with 2 applications a week apart, or Netra, which is you just put in 1 application and the effects can last for up to a month. Both of these preparations contain a steroid, an antifungal, and an antibiotic. The antifungal is terbinafine and the antibiotic is chlorphenicol in both cases. And it's just the steroid component which is different. So mometasone, which is in Netra, is a stronger and longer lasting steroid than is contained in Ocernia, which is why the effects are longer lasting with the Netra. Do you need a systemic antibiotic for external ear disease? Usually not. There's not very good penetration to the ear canal. It has to go from the gut to the blood and then all the way back to the ear canal. And it is much better to use topicals. Also, topicals don't affect the rest of the body. Of course, there are some exceptions, and they would be middle ear disease, or if there's infection outside the ear canal as well, such as a paraoral abscess or pinal disease. And what about a systemic antifungal? This is a bit different because azoles are metabolized via the skin, so they actually do get to the skin, and especially in a clean ear, you can get quite high levels actually within the ear canal. Still not as good as a topical drop, but if for some reason you can't put a commercial antifungal down the ear, for example, if there's no tympanic membrane, then an oral azole could be useful. Optimists can compound topical antifungals that are middle ear safe, so that's something to ask them about if needed. And if you do use an oral azole, of course, you've got to warn the owners about liver toxicity. This used to be really popular, Meliseb in the ears, when there wasn't anything better to use. It is a really good antifungal, but just not in the ear. So there are better things that we can use these days. Shampoo just makes ears red, angry, wet, macerated. It's great for the skin, but don't put it in the ear. It's a very good idea to show owners how to put drops in. We use syringes, and because if the owners just put the end of the ear medication, drop it in the ear, they can't see what's coming out. So, and when people put those applicators down the ear, sometimes they can cause ulceration and it makes the dog resent treatment. So we get them to draw it up in a syringe and administer it without touching the ear canal. Just use your judgment about what volume of drops to use based on the size of the ear canal. Generally about 1/2 ml for a cat or a small dog, about 3/4 ml for a medium-sized dog, and about 1 ml for a Labrador-sized dog, and possibly a bit more if the ear canals are really huge. Always plan to recheck them in 1 to 2 weeks, depending on how bad the ear is. 1 week if it's terrible, and 2 weeks if it's normal, and or normally bad, I should say. And when they come back in, ask them if the ear medication is all gone, because if they say no, we've still got lots left, that's a bad sign. If they say yes, it is all completely used up, that's good. And then we just continue to monitor. So I slowly back off. If the ear is terrible and I've checked it in 1 week and it's good, then I might double that time. So see it in 2 weeks. If it's still good, then see it in 4 weeks, etc. So I have had a referral of a dog that the vet did everything absolutely perfectly. They did their cytology, chose the right drop, and it was referred to me because it wasn't getting better. And the owner said that they were worried about putting the drops in the ears and so hadn't used them. And literally all I said in that consultation was to use the drops that the vet had given them, and the ears resolved. So just reassure the owners, you know, people aren't used to putting drops in their dog's ears. that most people don't really like being watched, but if you're just encouraging and reassuring to them and let them, you do one ear and let them do the other, it can, it's obvious to us how to do things, but sometimes it's quite surprising, just the little tips that you can give the owner that you wouldn't think that they would not know how to do something, but sometimes they really don't. Lastly, you have to consider owner expectations. I think it's probably one of the most important things that I've learned since I was a new graduate, is that you need to be realistic and honest with the owner from the beginning, and it saves you having problems later on. So managing owner expectations is really important. And if I was referred a dog whose ear looked like this, I would be being very conservative about my prognosis for this dog. If the ear canals have actually calcified and turned to bone, you're not going to be able to fix this dog's ears. So if I think it's pretty hopeless, I will usually say, look, we'll give it one really good go. And if we're not winning, then I think you should have surgery. And I'll bring that up right at the beginning. Most owners are quite horrified about surgery, but sometimes it honestly is the best option when the dog has had years and years and years of pain and difficulty, and the owners have spent a fortune on eardrops and struggling, and the ears look like this. Maybe surgery is actually the best thing. So I'll always bring it up if I think that I'm not going to win. My thing that I would do in a really proliferative ear would be to try prednisone at 1 milligram per kilogram for a week. And at the end of that time, if there's absolutely no progress made and you can't even find an ear canal to put your cotton tip in, then it is time to refer to surgery. So thanks very much to Elanco for the chance to present this little vet space module, and I really hope that it has been useful and given you a few tips for treating your difficult ear cases.